Hello and welcome everyone. I am Dr. Kshitij, Vitro Retina surgeon and your ophthalmology faculty at Medicoz community. So today we are going to discuss some MCQs and vascular disorders in retina. So before moving on to the MCQs and vascular disorders to retina, straightway let's jump to the first question, which is on the anatomy of macula. You need to know this before we move on to that. So the first question says the distance of fovea from temporal margin of optic disc is. Your options are 1 disc diameter, 2 disc diameter, 3 disc diameter and 4 disc diameter. So the correct answer here is 2 disc diameters. Let us see how. So as you all know, the color of retina is purplish red due to visual purple of the rods. Retina is divided into optic disc, macula lutea and peripheral retina. So now let's see the macula. It is grossly 5.5 mm in length. So the central part is called as fovea, and in the center of fovea there is foveola, there is a umbo, clivus called as light reflex also. So just beyond the fovea, which is fovea, the length of fovea is 1.5 mm. It is same as the length of optic disc. So beyond the fovea there is a part called parafovea, and beyond parafovea this area is called as perifovea. So the question that we were asked is, how long is the fovea from the temporal margin of the disc? So it is approximately 2 disc diameters, okay, which is 1.5 plus 1.5. As we saw in this, the fovea length is 1.5, parafovea is completing to 2.5, and the rest of the length comes to 5.5 in the macula section. So this is just an image to show you that the center part is foveola, and grossly the arcades superior and inferior, they cover the macula. This whole part is macula. Okay, so moving on to next question. Question number 2. A 40-year-old male with a history of newly diagnosed systolic blood pressure over 200 mm of Hg presents with a 3-week history of bilateral blurry vision. Okay, so his visual acuity was 20/30 in one eye, that is right eye, and 20/120 in the left eye. So the left eye visual acuity is affected here. The patient's systolic blood pressure is 200 mmHg and he is a newly diagnosed hypertensive. Okay, the rest of the examination was unremarkable. Which of the following findings is least likely to be seen on his fundoscopy? So now, as we have seen the question, what we have read is all the features of hypertensive patient. Also his one eye is affected, that means the hypertensive retinopathy is setting in. So what we have to look in the option is which of the following are the features of hypertensive retinopathy and which of the following is not a feature of hypertensive retinopathy. So basically what they have given is arteriolar narrowing. Yes, it is a feature of hypertensive retinopathy. Intraretinal microvascular abnormalities. No, this is not the feature of hypertensive retinopathy. This is a feature of diabetic retinopathy. C is cotton wool spots. Yes, it can be found in hypertensive retinopathy. And D is papilloedema. Yes, it can also be found in hypertensive retinopathy. So coming to the grading of hypertensive retinopathy, we know that grade 1 has arteriolar attenuation along with the broadening of arteriolar light reflex, while the grade 2 has generalized narrowing of the blood vessels along with focal arteriolar attenuation, and along with that Salus sign, that is deflection of veins at the AV junction, that is arteriovenous junction, can be found. It's called as Salus sign. Grade 3, there is bonnet sign, gun sign and copper wiring of arterioles. What is bonnet sign? It is banking of the veins distal to the endings. Gun sign is tapering of veins on the either side of crossings. Along with that, what you can get is flame shaped hemorrhages, cotton wool spots and hard exudates. Okay, are we clear here? Grade 3 is very important in the diagnosis of hypertensive retinopathy. And in the grade 4, we find all the grade 3 changes along with silver wiring of arterioles and papilloedema, that is disc edema. Okay, so moving on. Also, something about IRMA that you should know, the IRMAs are found in severe NPDR grade of the diabetic retinopathy. Okay, and how do they look? They look like this. They are irregular segmental dilatations of the retinal capillary bed. These are compensatory dilatations actually because of the pre-existing vascular channels, that is shunt vessels. Okay, and these are distinguishable from the pre-retinal new vessels because IRMA remain confined to the retina and they do not leak. When fundus fluorescein angiography is done, they will not leak except at their growing tips. Okay, so moving on to the next question. Next question is question number 3. They say that a 9-year-old boy presents with 6/6 vision in the right eye, and in the left eye he has only hand movements vision. So on fundoscopy, the right eye appears normal, while the left eye shows retinal detachment, that is RD, along with subretinal yellowish exudates and telangiectatic vessels. What is the most probable diagnosis? Okay, let's see what we have been given here. So the vision is 6/6 in one eye and the other eye is completely affected, that is vision is hand movements. While on fundoscopy, the good eye is normal, while the left eye is showing an RD, that is retinal detachment, along with subretinal yellowish exudates. Yeah, subretinal yellowish exudates. And how are the vessels, that is vasculature? It is telangiectatic. So here we also see that sometimes in such kind of patients you can see yellowish glow on the dilated examination. And where is the yellow glow seen? It is in the Coates disease. So answer here is Coates disease. Okay. Coates disease has telangiectatic vessels, yellowish exudate subretinal, and it can have retinal detachment. So if you see the option C, that is retinopathy of prematurity, it is usually seen in premature babies, and 9 years is not the usual age of presentation in ROP. It is there in Coates disease. In ROP it will be early, and the patient usually will be premature, and there will be a white reflex in ROP. So coming to the option B, FEVR, familial exudative vitreoretinopathy, yes, it can present at this kind of age, but the features will not be like this. There won't be yellowish exudates, there won't be telangiectatic vessels. FEVR will always have a traction. Okay, so it is very completely different from what we are seeing in the question. And option A, sympathetic ophthalmitis, is not to be confused with all of this. It is very different, does not indicate with what we have given in the question. So coming to the Coates disease, it is very common in the males, boys, as compared to girls, and presenting age, as we have been given in the question, it is young age. Okay, what features do we see? We see retinal telangiectasia. As you can see in this figure, the retinal arteries, they have formed a telangiectatic network. Aneurysmal dilatation can be seen in the vessels. Yes, you can see in this figure, if you can see it very clearly. There is sheathing of vasculature, more common in the temporal and inferior quadrants, and majority of microaneurysms are fusiform rather than saccular. Initial stages, there will be vascular abnormalities. As the disease progresses, there will be exudation of the fluid. Okay, there can be exudative RD here in Coates disease, produces subretinal deposits. And what are these subretinal deposits called? It is called as light bulb appearance. Okay, so remember, this can be asked as MCQ. Coates disease, you can see light bulb appearance. This is just the fundus fluorescent image that I have included for your reference. How does the Coates disease see? There are areas of complete absence of vascularization, along with the aneurysmal vessels seen, dilated vessels and tortuous vessels seen, along with the retinal telangiectasia that you can see on the fundus fluorescent angiography. So you must remember this, that in the fundus fluorescent angiography, the things that you are supposed to see, as we have seen the question of anatomy here, there can be foveal avascular zone in the center where we have seen the fovea, and it can be increased in certain vascular diseases also. So remember this point also. But it's very important to note that Coates disease is usually causing yellow glow. It's seen in the young patients, and as we have seen in the questions, the features are retinal telangiectasia, aneurysmal dilatation, and exudative RD, along with the light bulb appearance, as we can see here. Okay, are we very clear with what questions we have seen before this? If you have any kinds of doubt, you can message me, or you can comment in the inbox, or you can reach us anytime for this. So can we move to the last question of today? Okay, let's move on to the fourth question. The question asks you here, what are the causes of expanding blind spot? Okay, they are saying causes of expanding blind spot are all except. So we have to find out which is not the cause of expanding blind spot. Okay, so is it A, POAG, that is primary open angle glaucoma? Is it B, hypoplasia of optic disc? Is it C, papilloedema? Or is it D, medullated nerve fibers? So what is your answer? Okay, it is very clear that expanding blind spot will be seen in the perimetry. So which of the cases will do perimetry? It is definitely seen in POAG, that is primary open angle glaucoma. It is seen in papilloedema because it's a neurological, it's sometimes neurological. Medullated nerve fibers, yes, they will present as expanding blind spot, but the answer here is hypoplasia of optic disc. Hypoplasia of optic disc will not present as expanding blind spot. Okay, so what is important for you to know here? See, we'll see it in the form of images. What is this? This image is papilloedema. You can see all the margins of the disc are blurred here. So this is papilloedema. Okay, what is this? This is myelinated fiber around the disc. So it is obscuring one of the margins of the disc. And what is this? This is cupping seen in the disc. This is primary open angle glaucoma with the cupping seen, and this is myelinated nerve fiber. So this image that I had shown here is actually hypoplasia of optic disc, and hypoplasia of optic disc will never cause expanding blind spot. So physiological blind spot basically is an area of absolute scotoma, okay, in the visual field, caused due to absence of photoreceptors. Okay, where there are no photoreceptors, rods and cones in the region which is preoccupied by the optic disc. So lesions affecting the optic disc, okay, can expand the blind spot. So whatever lesions are there which are affecting the optic disc will expand the blind spot. Wherein the papilloedema, it is a passive disc swelling, okay, associated with the raised intracranial pressure. At the edematous optic disc is swollen, affecting the optic disc region, and it can expand the blind spot. Whereas the medullated nerve fiber is a condition which is causing abnormal myelination of the nerve fibers of the retina. Normally myelination starts from the brain and it proceeds downwards, stopping at the level of lamina cribrosa, and you know that lamina cribrosa stops here. Okay, so optic nerve hypoplasia is most common congenital optic disc anomaly, okay, that presents due to underdevelopment of the optic nerve. The optic disc is surrounded by the yellowish pigmented ring known as double ring sign here. Okay, yellowish pigmented ring known as double ring sign. So please see very carefully, there is a double ring here. Okay, but it does not cause any expanding of the blind spot. Okay, I think we are done with discussion of today. Thank you so much for your patient listening.